Much. Everybody back from on the web, the 3,375 people that are on the web watching us. Actually, it's not that many. We're going to have a session we traditionally have every year of inviting the agencies that are involved in disability statistics, the collection, and also the potential needs for those data. People working on trying to expand the take of disability-related questions and disability-related data that's asked. And so I'm going to just start really fast, not going to be introducing people. This is the modern age, people can Google you. So Richard, if you want to take it away.
Sure, and I think we're going to start, Savi is going to have some opening remarks, and then I'll talk about the Drive website. So Savi.
Where's the clicker again?
Yeah, and is the PowerPoint pulled up?
Yeah.
Okay,
there we go.
PowerPoint and the clicker. Oh, there it is.
All right. Happy early Valentine's Day, everybody. I know this was held last year on Valentine's Day, and I remember that. Today, this time, you decided to do it a little early. Good morning, everybody. My name is Savi Swick, and I'm from the Office of Disability Employment Policy. I'm here with my colleague, Richard Davis. And of course, you probably already know Office of Disability Employment Policy, also fondly known as ODEP. How many of you know ODEP? Pretty much all of you, but I'm still going to tell you a little bit about our agency. Let's do here. First, I'm going to tell you a little bit about our agency, and then Richard will showcase a data project that we have worked on. So ODEP is the only non-regulatory federal agency that promotes policies and coordinates with employers and all levels of government to increase workplace success for people with disabilities. Our mission is to develop and influence policies and practices that increase the number and quality of employment opportunities for people with disabilities. Because we don't have regulatory authority, we use research findings to influence disability employment policies. One of our major priorities right now is the research in stay at work, return to work. We believe when an employee experiences an illness or injury, and as a result, work disability, by intervening early, we can assist in keeping that employee attached to the workplace. With this approach, we hope to impact large numbers of employees who usually end up leaving the workforce after an illness or injury to continue to remain engaged in employment. We believe these efforts will have numerous beneficial impacts to the individual, the workforce, the economy, and the society. We are also on the verge of deploying a nationally representative survey of employers. ODEP has done a similar survey about 10 years ago, in which Andrew was also part of. And the second survey is expected to show us any changes since then and policies and practices in disability employment since then. So we are also doing a number of research projects in collaboration with DOL's Chief Evaluation Office, and a number of those will wrap up this year. The final reports of these projects will be available later this year. I hope you will visit our website and check those out. Some of these research and evaluation activities are focused on learning how our policies and practices impact the public workforce system. One such effort that included a data project was called the Drive. Now my esteemed colleague, Richard Davis, will talk a little bit more about that.
All right, thanks, Savi. All right. Thank you. As Savi mentioned, I am Richard Davis. I'm a policy advisor on the Workforce Systems Policy team at ODEP, and I'm going to talk a little bit about a website that we have called Drive, which stands for Data and Resources to Inspire a Vision of Employment. The URL, it might actually, we were going to do a live demo, but we didn't know if connectivity for the internet might be an issue, so I'm going to be describing screenshots, but actually the website is mobile phone compatible as well as if you're on a laptop. It might actually be a little easier if you'd like to follow along with the walkthrough of where to find things on the page to do that. So the URL is www.drivedisabilityemployment.org, and it's hosted through the Lead Center website. So our vision for the Drive website was actually an intersection of policy, practice, and data, and we wanted it to be able to be used by whether it's policymakers, advocates, researchers, a one-stop for you to be able to find the data you're looking for in one place, and also to quickly be able to get the sources of that data, as well as finding out policies that are in a given state. It actually grew out of ODEP's Employment First State Leadership Mentoring Program, or EFSLMP. We really like acronyms in the government. So EFSLMP, we require states that receive technical assistance in that to get commitment letters from their state intellectual and developmental disability, mental health, labor, education, vocational rehabilitation, and Medicaid agencies. Usually states that apply will also submit things like maybe a letter from the governor showing, you know, the statewide support for Employment First. A lot of times the UCEDs, the University Centers for Excellence in Developmental Disability, will also be on board to help out with the Employment First implementation, the state DD councils. So we're really always excited. Over the history of the program, which started in 2012, there were 22 states, and we've supported, and this year we're supporting 13 states: Arkansas, Georgia, Illinois, Iowa, Louisiana, Maryland, Michigan, Missouri, Ohio, Pennsylvania, Tennessee, Utah, and the District of Columbia. So I bring that up because the structure of the website was originally envisioned to help out states to really monitor what's happening with that, but also since we're doing it for all 50 states, any state can benefit from this resource, and it's since grown even beyond Employment First to disability employment broadly. Actually, so when you go to the main page, you'll see a map, and you can actually click on any of the states in order to jump to that state's profile, but you'll notice at the top, again, if we were going to do a live demo, it's a little easier to navigate, but I'll read the top what it says. To navigate, there's a national data tab, state profiles, state comparisons, and advanced search, and an about section. So when you go into a state profile, it opens up with 3 columns, and that's going to be the latest data by year. So you'll see, like on this one, it says 2013, 14, and 15. And the general data there is from the U.S. Census Bureau. So if this one, I think this would, yeah, I used New Mexico. It gives you the population, number of people with disabilities. There's actually over 100 data points on each state profile. And when you go down by tab, it includes the general things from U.S. Census Bureau, SSA outcomes, and if you look at like the bottom of each table, there's in the small text, those actually will link you directly to the source where it was pulled from. So the SSA is coming from SSA data, and we're only pulling from federal data sources, and the website is updated quarterly as new data becomes available. But we also include mental health outcomes, that's coming from SAMHSA, workforce development outcomes, VR outcomes coming from RSA, IDD outcomes, education outcomes, Ability One program statistics, and wage and hour division statistics as well. So all of those are pulled from those federal resources, and as they are updated each quarter, the website also reflects that. So when the 2016 data became available, this moves over. But the data for 13, even though it won't be displayed on the most recent 3 columns, is still searchable within the website itself. So then another tab on the state profile. So you'll start with the state data. We also included a new feature this year called the WIOA profile. So as you know, each state had to do a Workforce Innovation and Opportunity Act state plan. And we've actually broken down, you can go and at the very top you can download your state's full state plan, but you can also, if you're looking for a particular topic, any references to, for example, customized employment, blending and braiding, Section 188, the Disability Employment Initiative, state programs and pilots that support competitive integrated employment, financial literacy, benefits, school to work transition, data collection, small business and entrepreneurship, career pathways and employment networks. You can actually click on those tabs and it will expand and will give you a cited page number of where that is in your state plan, but will also quote the text so you can quickly get to it, and there's even a state comparison tool where you can compare your state plan to another state's or whichever two you'd like to look at. And then the third tab at the top is on policies and initiatives, and this is a really cool kind of database, and everything has a citation and a permalink that will link you to where this is hosted on state government websites. So this one for New Mexico, in parentheses it says there are three sources of legislation, 1 executive order, 7 policies, 5 partnerships, 3 systems change funding, related resources, training and capacity building 6, 0 enforcement cases, and 7 Medicaid and employment. And they originally appear in chronological order from the newest being at the top, like any kind of new things there, but then you can click on the ones, let's say you just want to see the executive order, you can click on that and then boom, it'll take you to the one there. As I mentioned on the main page, there are some advanced search options, so if you're looking for particular policies related to a state government agency, you can go ahead and check the boxes and you can generate which states you're looking for and it'll narrow it down for all of the things that are linked on the website. We also just launched a subscription tool. So let's say you're in Maryland and you want just updates on Maryland, you can click that, or if you're in Maryland and you just want updates on the IDD system, you can check that, and anytime data or resources are added to the website that affect those areas, you can actually get an email notification updating you of that. So that's kind of a basic overview. I usually go more in depth with the website demo and things like that, but that kind of gives you the basics of it, and I encourage you to check it out. Again, it's drivedisabilityemployment.org, and there are lots of different features you can use on it. And with that, I will wrap it up and turn it back over.
Great.
Thank you.
Thank you, Richard. Who's up next? So, who took my agenda? Just come on up, everybody. Everybody just come on up after the next person's done, so no need to wait. We want to save as much time. Yeah, we're switching slides now. Kate, are you back there? Just push this to go forward, this back.
Oh, good. All right, I don't like public speaking. Hi. My name is Danielle Taylor. I'm with the U.S. Census Bureau. We're going to talk today about the disability data that we produce, some of the products that we have, and releases that we've made in the last year. All right, so the Census Bureau produces a lot of data, and as much of it's used in the statistics here, especially the American Community Survey. 3 of the surveys that we have disability data in are the American Community Survey, the American Housing Survey, and the Survey for Income and Program Participation. In 2014, the SSA also sponsored a supplement to the SIP, and I'll go into some details about that later. It has a wealth of disability data available in it. And then when this is over, I'll talk about a recent research project a colleague and I did looking at the core disability set and the health conditions that are captured within it. So, as many of you are probably aware, the 6 questions used in the American Community Survey are also used in many of the other federal surveys that we have, including the 2014 panel for the SIP. As a highlight to touch on these questions, they cover hearing disability, seeing disability, cognitive functionality, ambulatory functionality, self-care, and independent living. I have information on those if you need them. You can ask. So the American Community Survey has by far the largest sample of any of the federal surveys that we conduct. In 2016, for example, the ACS interviewed more than 2 million households and more than 160,000 people living in group quarters. As a result, the ACS produces estimates for a variety of smaller geographies and is used widely among local governments for project planning and resource allocation. From the ACS, we get 1-year and 5-year products, which I was told that you guys were familiar with. I'm not sure if that's true. The 1-year estimates are used for populations of 65,000 or more. That's nation and state, and most large counties or large cities like New York City, Sacramento, Washington, D.C. And the 5-year product is used for all geographies within the U.S. down to the census tract, which is a little tiny geography. We also have a new data product, which are 1-year supplemental estimates for populations of 20,000 or more. This was meant to replace the 3-year product that got discontinued. It uses the 1-year data for selected estimates. Data for the ACS is, available on American Fact Finder. We have a lot of tables, a lot of them specifically with disability crossed with other socioeconomic categories. And we also have a few tables on group quarters, which look at institutional and non-institutional populations like nursing homes or prisons. And within there, we have a statistic for the disability status that is collected within the ACS. All right, a tool that is available on the Census website is My Congressional Districts, and what this provides is disability status along with some other estimates for congressional districts in all of the states within the U.S. And actually, to a question earlier, this is an infographic produced by the Census Bureau that looks at each type of disability and breaks it down by age and sex at the nation level, not the state. So this is an example of the ACS in action. Woohoo! So the American Housing Survey, I'll go over it briefly. It's conducted every 2 years. Data was produced last year, so the next next data set will come out next year. The AHS looks at the size and composition of housing in the U.S. for 25 major cities as well as states in the nation. It covers a variety of housing and household characteristics that might be of interest, like neighborhood safety, the availability of public transportation, but also like whether any home improvements were done for accessibility reasons. There's an infographic that gets into how this gets used. It's really fascinating. I liked it. Anyway, estimates are available on the table creator, and you can make lots of things. So fancy infographic. I very much liked this. What this is it's a merged file of the ACS and the AHS that explores the intersection of disability and accessible home features. So some highlights from this are things like 20% of homes with an older adult have wheelchair accessible cabinets. 39% have handrails in the bathroom. Also down at the bottom, the very ugly green and orange bars says that 79% of older adults with difficulty using the bathroom live in a home that don't have accessible bathroom features. So, all right, this brings us to the SIP. The SIP is my personal minor obsession. So the SIP went through a redesign in 2014. Notable changes from that are that data is collected every year as opposed to every 4 years. And also everything is collected in the core survey as opposed to using topical modules like in previous panels. The SIP asks about a variety of topics like public programs, health status, living conditions, and medical utilization. Wave 1 was collected in 2014 and Wave 4 was collected in 2017. The SIP also has a online code book that allows for interactive variable lookup. It's very, very fancy. Disability in the SIP are the 6 basic ACS, as well as 3 additional questions specifically targeted at children, and 3 questions that cover different work limitations. Because SIP is a longitudinal survey, it allows for longitudinal analysis of disability along with the wealth of other socioeconomic topics conducted in the survey. Yes, that's everything. Woohoo! I pushed the button? I pushed the button. Awesome. So as I mentioned, the SSA sponsored a supplement to the SIP in 2014. It was a one-time supplement that was fielded as a follow-up to the Wave 1 interviews. It includes a number of topics previously collected in SIP topical modules that the SSA just needed in order to fit into the analysis that they do. Disability within the SSA was quite large. It had more than 130 questions on limitations and covered a lot of disability areas like work limitations, likelihood of working, ADLs and IADLs, as well as psychological conditions and symptoms. The SSA panel SSA can also be merged with the 2014 SIP panel, so you can take that as a starting point and then do longitudinal analysis as the waves from the SIP come out. Health conditions within the SSA were redesigned from the 2008 panel. It includes the original 29 categories in there, as well as 10 additional categories that kind of expand out what you can see and reduce the amount of people in the other category. Really hate public speaking. Okay, so that takes care of the surveys. So a colleague and I, who is sitting there, which is why I keep pointing at her. What we wanted to do was look at the 6 disability questions that have been kind of established as HHS's minimum standard, and look at what health conditions are captured by them. What this comes from is I got a lot of data user calls kind of wanting to use the 6 as a proxy for a condition that they wanted to measure in their study. So that's what I was like, okay, well, what health conditions are collected? So that's what we looked at. Respondents that we used were all adults, 18 years and older, and all responses were reported. So the first thing we did was identify people who reported a disability using one of the standard 6 disability questions. And what this graph shows you is the type of disability that a person reported when they reported one of the 6 disabilities. And what you see in the younger ages is that the cognitive difficulty really dominates, and as people age, ambulatory and other limitations kind of become more prominent. So in part because I really like the path of the cognitive disability, the next slide, the last slide, kind of goes into the health conditions that were captured by that question. And when you think of health conditions, perhaps in cognitive disability, kind of the first thing that might come to mind is dementia. And we do see that dementia is a strong contributor to reports of cognitive difficulty in the older ages. But in the younger ages, what we see is that learning disabilities and mental and emotional conditions are actually stronger contributors. And so the takeaway from this is that if you're going to use this question as a proxy, age may well play a factor into what is being collected. So that is everything. Yes, last 2 slides have information and contacts.
Thank you.
How to do.
Great. I would make a pitch. Thank you. I would make a pitch for the SIP as well, because the new redesigned SIP allows people to report up to 7 jobs they had over the course of a year, and that's unprecedented. And so the idea of having multiple crappy jobs, that's a technical term, is something that can be investigated in the SIP like never before. So Julie Weeks, you're next.
Thank you. There are decidedly fewer woohoos for the federal people who come up. Just, I've noticed it in past years. Okay, good, just checking. I'm from the National Center for Health Statistics. It is one of the 13 federal statistical agencies in the U.S. government, and one of the things that I wanted to start out by mentioning is that the ACA mandates that that federal data collections from all of the statistical agencies, not just those that are health-related, collect disability data. And so as you hear from our federal partners up here and their data collections, you will see that that ACS minimum 6 question set, which was recommended by the ACA, is in fact now being collected in most of the federal data collection systems. And many of them are now putting out periodic statistics, either disaggregated by disability or their product is very specifically geared towards the disabled population. And I personally think that one of the most interesting developments since ACA is we now have criminal victimization statistics by disability and displayed among that population. So check out those Justice Department statistics. So moving on to what's happening at the National Center for Health Statistics. If you were here last year, much of this is a repeat, but it bears repeating, that the National Health Interview Survey, which is the primary data collection for health information in the federal statistical system, is undergoing a major redesign. The new content will be implemented fully in 2019, and there are extensive changes to the disability content, which I will touch on. My slides are very word heavy. I don't read every word, but you have access to those. Do go back and kind of look through it. There's a lot of disability content coming. There's a lot of disability content being moved off of the survey. The survey is undergoing structural changes as well, and those will be important for individuals who use the data. How the data are collected, how often they are collected, the type of respondent that the questions are administered to are changing, and I will touch on those. The body of the disability content for the HIS will primarily come from the Washington Group on Disability Statistics questions that have been developed. They are now the international standard for disability data, and you will see more of them in federal collections as well. And then just a few implications to consider if I have time. So again, since this is a little bit of a repeat, any major survey, especially one that's been in the field since 1957, continuously must redesign at various points. There's certainly an economic aspect to a need for redesigning, but more importantly is maintaining high quality data. And in pictures, what has been happening since the last redesign, which is 1997, is that our length of interviews have been increasing incredibly. To ask the many, many questions that are added on to that comprise the HIS, but also those that are added on through different supplements and by different sponsors, simply increases that length. And no one ever wants to take a question off of a survey. You'd rather kind of slit your throat. But when you try to go to these households and you say, "Hi, I'm from the Census Bureau, I'd like to collect this information. I'll be here for about an hour and 45 minutes," that's not working out so well. And you see that in our response rates over time. And if you know anything about the structure of the HIS at the moment, that blue line at the top is the response rates from the family module. But the disability data, much of it is collected from the sample adult, and that's that purple line at the bottom. So if we want to maintain high quality data, then we really need to restructure these surveys, especially with shrinking budgets. So the criteria for prioritizing content, there are many criteria, but this idea of very strong link to public health is a driving force. The questions that are put onto a survey in any given decade reflect the concepts and the definitions and the needs at that time. 30 years later, those things change. And so there has been a pretty intensive review of the content to ascertain, are we really still now collecting what is the right thing to collect now? A second criteria that I want to point out is actually the last one, and that's, can an estimate be produced with 1 or 2 years of data? That is a really important consideration when using these big national surveys. You will see analyses that combine 3 and 4 and 5 years of data in order to produce a stable estimate. If your population is so small that the HIS or any other major survey can't collect and represent it well in 1 or 2 years, it is likely going to be considered economically unfeasible to add questions to identify that population. So that's a major consideration. This is the current HIS content in 2018. It will be the last time all of these questions are asked. And if you read through this list, starting with ADLs and IADLs, basic actions, complex activity limitations, work limitation, one of the things, it's almost like a history of disability data collection. We could put it on a timeline, which I'm going to do that for next year. And what happens is this. So there are functioning variables, about 170 in the core section alone of the HIS currently. The ACS questions were added and added another 6 questions, variants of which are across the family, sample child and sample adult. And then the Washington group questions, once they were added, we are a national statistical office. We do comply with international standards. So those were added to the HIS about 10 years ago. This is not a new thing. Added another 63 questions. So pretend you are a sample adult and someone's knocked on the door and they've said they're going to be here for an hour and 45 minutes, and you answer the family section, and then you answer the sample adult section, and then possibly any other sponsored content. You've probably now been asked somewhere around, between 150 and 200 questions in the general functioning area. And if it's vision or hearing, you could have been asked basically the same question with a little quirky questions here and a little bit different response categories here over and over and over again. And by the time you get to that interview, where some of those disability questions now reside, you're saying enough is enough. So it's really untenable to maintain. So here's the look after redesign. This is what's going to be in the HIS in 2019, the material on the right. So if you love ADLs and IADLs, they're going. The basic actions, difficulty, complex activity limitations, I got to give a shout out to Barbara. I'm sure she's watching. They're leaving. A lot of the personal care questions are leaving as well. So what is left is the Washington Group short set, extended set, work limitation questions, social activity limitation questions, participation limitation questions, and then some very nice extensive child disability questions which have not been on the HIS before. I'm going to very briefly and quickly go through each of these sets. The short set on functioning mirrors the ACS question set. You see the vision, hearing, cognition, mobility, bathing. There is an important change. The answer category is not yes, no. So here, what we know is disability is not a dichotomy, it's a continuum, and these response categories reflect our need to collect information, not just on those who say yes or no, but those who have some or a lot or cannot do it all. So that's the short set. Those 6 questions will be on the HIS. That gives you a great disaggregation variable. But that's not all we need to know about disability, and there are far more domains of functioning involved, and that's what the extended set is for. The extended set includes more questions on hearing and cognition and mobility, and then extends across functional domains to add communication, to add upper body functioning, anxiety, depression, pain and fatigue, and all of those questions, which comprise about 63 questions, have more than just a dichotomous response category. I mentioned that we are adding the child functioning modules that have been developed jointly by the Washington Group and UNICEF. There are 2 groups of questions, one for 2 to 4-year-olds and one for 5 to 17-year-olds. Issues are very different between those 2 age groups, and this slide demonstrates the topics that are included in those modules and where there are differences between the 2 to 4 and the 5 to 17-year-old. There are 2 modules in development, so these 2 are not necessarily planned to be on for 2019. They are undergoing testing now. They have been tested in the U.S. and in countries outside of the U.S. The inclusive education module is one that really gets to this idea of beyond what you've answered to these functioning questions. What's the difference between your status your functional status, and your ability to participate in society. And for children, their major activity of participation is school. So there are questions about attitudes and the school environment and what accommodations can be made and what might some of those barriers be. And if a child in the sample is actually out of school, then there are reasons for being out of school. The second module that I wanted to mention is an inclusive employment module. I don't have a slide for it. The slide would look very similar to this because it is primarily for adults. What are the barriers to working? If you are a person with a disability and you are working, what accommodations have been made in the workforce, in the workplace, including things like transportation, but also things actually in the office. Again, that module is a little bit behind development from the inclusive education. It's already been tested in the US. It is now this month being tested in India, and more testing will come. So I'm going to move kind of quickly through this, but this is the picture of the structure of the NHIS once it is redesigned. The top half, the part in yellow, will be considered the annual core content, and it will contain most all of the disability questions that I have mentioned, so that you will get these questions asked annually. The middle section is called rotating content, and what I want to bring to your attention is that there are some questions that are 2-year rotating, 1 year off, 2 year on, 1 year off. There are others that are on 1 year off, 1 year on, off, at 1 year periodicities, and then there are 2 on, 2 off, 2 on, 2 off. So we're trying to get a lot of that content that all of our interested data users want onto the survey, but without asking it every year. That has implications when you analyze the data. Again, if you need to aggregate data across 5 years to make a stable estimate, but your favorite question is on a 1 on, 1 off kind of rotation, then you're going to need 10 years of data. So we really, there were some questions earlier, that very good questions, that really spoke to a need for smaller data collections, more localized data collections. When you get to the national level, you're really needing to measure things that really have great prevalence in the population. So this is the structure. Let me mention the bottom content. That is content, it's called sponsored content. If you have a check, you can buy a block on our quilt. And we are happy to do that. We need that. How many minutes do I have? 0. Okay, good. That's perfect. So you can read through some of these slides on the proposed, the implications of the proposed core modules, as well as some of the ideas about the rotating content. I've spoken to most of this. And then I think we're done. Yep. No problem.
Thank you, Julie. I would push for greater sample size so that we can do more state estimates from the HIS. Again, yes, she put money out. I have a check. It doesn't have any money behind it. You only said we have to have a check.
No, I know, I did. I'll
so
fix that
Alissa,
next year, too.
All right, so we want to go quickly so you have time to talk. Just push. Yeah, just push.
Hi, everybody. My name is Alissa Stevens. I am the acting team lead for the Disability Research and Epidemiology team with CDC's National Center on Birth Defects and Developmental Disabilities, specifically the Disability and Health branch. So I'm going to talk a little bit just about kind of where we sit and what our branch does broadly, and then more specifically about some of our current and upcoming data-related activities. So we are within, the Disability and Health branch is within the Division of Human Development and Disability. Also within the branch is the Office of the Chief and the Disability Policy Interventions and Programs team. As I mentioned, I'm the acting team lead for the Disability Research and Epidemiology team. So our branch mission is to promote the health and full participation in society by people with disabilities across the lifespan. And we've got 5 core principles that sort of guides our work: inclusion and accessibility for people with disabilities, a multi-level approach to address health disparities, evidence-based and innovative interventions, a research to practice model, and a diverse and integrated network of partners. So within the branch, our primary focus really is on the prevention of secondary conditions such as heart disease, diabetes, and hypertension for people with mobility limitations or intellectual disabilities. And then we also have some secondary areas that we work in on things like emergency preparedness and oral health. So we fund 19 state disability and health programs and 2 national centers on disability, which are all working towards improving health and quality of life for people with mobility limitations or intellectual disabilities. And these programs focus on a variety of health topics and take place in a variety of settings, and then have varying levels of influence, whether at the community, organizational, or individual level. We also work with the National Association of Chronic Disease Directors on a project called Disability Through Healthy Communities, and that funds 5 states, 2 communities in each state, to do some work at the community level. So moving to more of our data-related activities, one of the things we do, we develop and maintain Disability and Health Data System, which is our online interactive tool that presents state-level data on measures of health for adults with disabilities. So DHDS essentially allows users to identify differences in health among adults with different types of disabilities to compared with adults without disabilities. Right now, the system has 2013 and 2014 data based on the Behavioral Risk Factor Surveillance System data. We have disability status and currently 5 of the functional disability types, 5 of those ACS questions. We will be updating the site later this year with 2016 data, and at that point we will have all 6 of those. So we have a few different ways in the system that people can view the data. We've got interactive maps, which there's a picture of on the right side there of the slide. We also have state profiles and dual area profiles, and those allow you to kind of view one state and multiple health indicators for that state, or 2 states at a time. So a lot of our work, because we are focused on health, we use population-based data, mostly health surveys. So we use the Behavioral Risk Factor Surveillance System, NHIS, and we also use the National Health and Nutrition Examination Survey for a lot of our work. Sometimes, depending on the project, we will also use the ACS or SIP. And then increasingly, we have been looking at using administrative data, such as Medicaid data, to allow us to better identify and characterize health for individuals, specifically with IDD, who are more difficult to identify in some of the other surveys that we use. So this work has kind of been developing over the last several years, and currently we're funding 7 states to access and utilize their Medicaid data to identify patterns of health and healthcare utilization for people with IDD. So one of the other projects that we are sort of kicking off, just getting started, is building off of some previous work we've done, looking at antihypertensive medication adherence, again, among people with IDD. So this work is sort of going to test to see whether education and sort of reminders to fill prescriptions has an effect on adherence. And then finally, we have a seat at the CMS Virtual Research Data Center. So one of our team's analysts is able to access some of that data, and she's kind of getting up to speed with that, so we'll be able to conduct some of our own analyses of Medicaid data as well. So moving to some of our other data-related activities, we have, over the last few years, added some questions to Porter Novelli's Styles surveys. So these are surveys that are web-based, developed by Porter Novelli with technical guidance from federal public health agencies and CDC licenses the results of those surveys. So we've added questions about hearing difficulty, intellectual disability, physical activity, and emergency preparedness. And we're starting to kind of analyze and publish some of that data. Then in 2017 and again in 2018, we added a question to NHIS, which we're hoping will help assess why people are answering that they have difficulty with cognition. So that was cognitively tested and then has been on the survey 2017 and again in 2018. So we're hoping to analyze that once that data is available. So just to highlight a few of our recent publications, these are current as of, I think, November. So we have one looking at primary care providers and their recommendation of physical activity to adults with disabilities. That one was based on some of that STILES data that I mentioned earlier. Another one looking at daily sugar sweetened beverage consumption by disability status, contraceptive use among women with disabilities, and finally using 2 disability measures to compare physical inactivity among adults with disabilities. And then some of our upcoming work, we're hoping soon to have a couple additional papers out, one characterizing Medicaid members with IDD, looking at sort of how to identify them using that data set and demographic information, and then another one looking at, again, antihypertensive medication use among adults with IDD. Then later this month, which we're really excited about, the 7 states that we're funding to do the Medicaid work, we're actually bringing together for a meeting in Atlanta to kind of discuss sort of their progress to date, their challenges, lessons learned, and things like that. And then finally here, we are planning an update for DHDS, Disability Health Data System, for later this spring. And we are going to be doing a couple of webinars and other promotion and communication activities around that. So be on the lookout for that later in the spring, early summer timeframe. And that is all I have. Thank you.
Thank you. And next we'll have Jennifer Johnson. Hi, Barbara.
Hi, I'm Jennifer Johnson, and I'm the Deputy Director of the Administration on Intellectual and Developmental Disability. We're part of the Administration for Community Living. And for those of you, I think we have a lot of ACL friends in the audience here, but for those of you who don't know ACL, we advocate for older adults, people with disabilities, their family members and caregivers, and we fund a variety of programs that conduct a number of activities in the state, a lot around innovation, research, training, so that people will have more and better opportunities for community living. I'm going to be talking to you today a little more about the data needs. We do a lot of work in ACL around research and data on people with disabilities, both within AIDD, but also in NIDLR, and actually funded the work here today on the Compendium. But what I'm going to be talking about today is some discussions that we've been having around data needs to better inform what we know about the IDDD population so that we can better plan and have better policies in place for this population. Okay, so just to talk a little bit about the need that we have and why we started having these discussions. One of the needs that we have identified is that we are really in need of updated prevalence rates on this population. Right now, there are a handful of existing prevalence rates for this population, and they vary. The most commonly used one, or the one that we at least use within our programs and in our office, is the one that was developed through a supplement to the NHIS in the mid-1990s, and that prevalence rate is 1.58%. But we know that the population has changed, and we know that there have been great changes in the demographics in the United States, and that likely we also know that that prevalence rate that was developed in the mid-90s with the supplement to the NHIS was likely an underestimate of the population. And we also know that rates among children are variable, but also higher than the rates among adults. So a lot of pointers to us that we need to have updated prevalence rates for this population. This slide here just shows you the different prevalence rates that are out there through different research that was done, and shows you the differences in terms of prevalence rates for the ID population versus the DD population, both within child and adults. And that there is, like I mentioned, variability within these different data sets, particularly if you look at the child with developmental disabilities studies. Another reason why we've identified a need to have better data on this, both the ID and DD population, is because we really have concerns about the health of this population. And we really understand their health and health-related needs much less well than we do for other groups. And we also know that we spend more on this population and we have poorer outcomes for this population despite the federal and state investments to support their living. So we also know that they oftentimes have preventable health conditions and that there are a lot of health disparities within this population. But we know that, and we know that to a certain extent, but there's still a lot that we don't know about this population. And so we have identified that as a particularly great need for us. Just to drill down a little bit more in terms of what we do know that individuals or adults with ID/DD experience poorer health outcomes in a variety of areas, especially when we compare them to peers of their similar age. And that, again, these disparities are magnified if a person comes from different racial or ethnic backgrounds and also have an intellectual disability or a developmental disability. We also know that this population has greater risk for chronic conditions when we compare them to the rest of the population. So another reason why we need to have better health-related information on this population. So we've been having, again, some ongoing discussions about how can we get better prevalence rates, how can we get better health-related information on this population. And in those conversations, we looked at what are the different approaches to getting that information, one of which is through surveillance methods. And in terms of this research method, we know that it allows for repeat administration of questions. It allows researchers to track conditions over time. It also allows for pooling of data and making population-based comparisons. But when we apply the surveillance method to the ID/DD population, you find some challenges in using surveillance methods, so much of which has been talked about today. One of which is just how do we define this population and how to find the population itself, knowing that many surveillance surveys are done of people living in the community, and we do have people with intellectual and developmental disabilities who are still living in institutions, so they will be missed. And again, that was a point that was made earlier today. And then another point that was alluded to earlier was just on the low prevalence rate. So again, creating challenges around how do we actually find and locate these individuals to ensure that they're included in the survey, even though we have laws that require that they be included in these surveys. Another method is longitudinal approaches, which allows for looking at the natural history and understanding trends. But we all know the challenges with longitudinal methods, which includes maintaining connection to individuals and the potential biases in the retention of participants, and that it's not always population-based survey or methods. How much time do I have? Just want to make sure. 4 minutes. Okay. Another possible method for getting better information on the ID/DD population is through the use of administrative data, and we heard a little bit about some of the work that's going on related to that. But it allows for investigation of how social factors and other structures, organizational structures, both affect access to care, the quality of care, and the cost of health care, and ultimately the health and well-being of individuals. And it also allows us to look at patterns and entire health systems to look at the outcomes for individuals who are enrolled in particular systems. And I think this was also mentioned earlier this morning that there's increased work to look at how we link different databases and harmonize across different data systems that allows us to know more about specific populations based on what's in the different data sets, and therefore allows us to answer new questions. So we've also taken a look at how is this being done right now, and I think you've heard a little bit about that this morning, but some of the things that are going on right now, you may be aware of the Special Olympics Healthy Athletes Survey that is done, and there are a lot of benefits and strengths to this research, including that it is one of the largest data resources for the ID/DD population, and that it has been used in multiple studies looking at different areas for this population. But there are limitations in that the data isn't nationally representative, and that there are difficulties around getting individual identifiers in the data. My office funds what is called the Residential Information Systems Project, or RISP, which a lot of you are probably familiar with. And this is a longitudinal study that looks at trends in residential settings and where people are living, and also the funding for that. So it is through this study that we're able to get some updated prevalence rates that is, again, based on the supplement to the National Health Interview Survey that was in the mid-90s. But there are limitations to this data because it does not look at the health of individuals with intellectual and developmental disabilities. So again, not a specific investment in that area. You all are probably also familiar with the National Core Indicators, which is a project that's in many states in the District of Columbia, looking at people who are receiving services from the state and looking at a variety of areas related to their health status, but other status areas as well. But the limitations to this study as it relates to what it is that we want to know is that the sample is limited to people who are receiving services, so it doesn't allow us to get at people who are not receiving services, and that proxy reporting is allowed for parts of the data set. We've also looked at the National Health Interview Survey, and we've had a number of conversations with our colleagues in NCHS. Again, I think this audience here is probably familiar with the NHIS, and you just heard about updates to that, and I've talked about the supplement to that survey. But what I wanted to point out here is that that supplement has been useful to doing additional research on the disability population. But we also know, and as was described just now, that survey is changing, and we're getting less specific information about the ID/DD population. I'll just quickly go through this in the interest of time, just looking at how the NHIS data has been used in different studies. Here's a listing of those, and just to acknowledge, this work has really been facilitated by Gloria Cron. She's been working with us in sorting through how do we address these data needs. And so she did some work to identify these studies that had been done. This also looks at the number of publications by year, and that is kind of scattered in terms of how common it's being used. These slides just show you what the focus areas of the studies have been. Again, in the interest of time, I'll go through those. In terms of the limitation of the NHIS, again, it does not include institutional populations, which I mentioned earlier is an issue, and it may also exclude people who live in places such as group homes. And it will not include issues specific to the ID/DD population and where they might have needs that are specific to this population. So, what we have, again, we've been exploring how can we get better data on the ID/DD population, both in terms of prevalence rates and their health status, and again, looked at all these different areas as possibilities for getting better information. And within that, we've been trying to sort through whether we should pursue including questions or trying to include questions on surveys like NHIS or the Census so that we can identify the ID/DD population And in November, we convened a meeting of several experts that are doing work in this area, people who have a lot more expertise than I do. And they really did encourage us to continue to pursue that path. So we are convening a group that will help to develop a question for identifying the IDDD population on surveys such as NHIS and possibly to be included on the Census or American Community Survey if possible, if we can come up with a question that works within the parameters of such as the parameters that have been identified for the NHIS. But we've also been encouraged to look at other ways in which this data can be collected. So we've also formed a work group to explore further the use of administrative data and where we might be able to get better standardization or harmonization across the different data sets and how can we support that. And then a third area that's been identified is something, again, that's kind of been alluded to here, is what are some other possible ways in which we can get data? Are there special surveys that we can do on this population to, again, get a better sense of the prevalence, but also their health-related needs? So that's where we are at this point in time. We hope to have the work groups working this spring and finished up over the summer to have some ideas for what we do in terms of next steps. So thank you for your time and thank you for including us to share our work in this area.
Thank you, Jennifer. We're going to go straight to questions. So if you've got any questions, if there are any questions people want to ask online, we will have an opportunity to do so. We have about 15 or so minutes. Are there any questions? Dave, go ahead. Right down here. All right, we'll give. Go ahead,
Oh,
Joanne.
I need to go first? Oh, goodness.
Sure, you're first.
Okay, Joanne Schneider, Chrysalis Collaborations, and GWU. This was a really exciting panel, and I'm looking forward to seeing how this work comes out. Richard, and that data set's really nice. Julia, and everybody else, I want to ask some additional questions and make some suggestions about the IDD issue, because I think it's huge. So I'm wondering what everybody is doing to try to disaggregate that cognitive data set into something that distinguishes between mental health and dementia. And then for IDD, I would really strongly encourage everybody not just to look at the population that is served by the Developmental Disabilities Administrations, which is what you're getting from the Medicaid data, but to get to everybody else, because there's a huge population with IDD that are too high functioning, and high functioning can mean many different things. So I'm wondering how people are thinking about getting at that. And also, I'm wondering if people are aggregating in, for example, the voc rehab data and so on, and some of the stuff that colleges may have and the school districts may have.
Does anybody want to grab that?
It's very, the IDD population in particular would be a very difficult population for the HIS on an annual basis to identify. Part of the problem, and we all up here have kind of mentioned it, is there are different definitions, and you speak well to the fact that, you can have programmatic definitions for the receipt of benefits, and then you can have other, more general health definitions. And then you have different levels of functioning, so you can't create a definition that is necessarily tied to one's, for example, independence in the community or something. So this is a real special population with real special, issues in terms of collecting data. And I think I'm going to let Jennifer answer the rest of that.
Sure, thanks. So I think you've described well what it is that we're trying to work on and figure out. So I can't say that we have the answers, but we're trying to come up with some of those answers and solutions. And one of the things I didn't mention, but I think is important to mention, is we have been both talking about the individuals with intellectual disabilities, but also individuals with developmental disabilities, and it's important not to lose individuals with intellectual disabilities within this population or within this discussion, because they're probably the most overlooked population, and trying to understand the population itself and, again, their health needs will be very important to how we can use that information to better plan and develop policies that will address the needs of the population itself. So I can't say that, again, we have any of the answers, but what you've identified is what we're trying to work on and develop a solution for.
Also, the NCBDDD projects related to Medicare, CAID data is trying to get at that too, and looking at unfortunately, by necessity, it uses a very clinical definition, basically ICD-9, ICD-10 codes to identify people with intellectual disabilities. Kim Phillips, who's in the audience somewhere, will be presenting some of our research that actually looks at private claims as well. So we have the all-payer claims data, health insurance claims data in New Hampshire, and we've been looking at, with funding from NCDDD, people who are typically not captured, so people who are receiving health insurance support through private commercial carriers. And they look quite different. So that's something we're trying to do. Any other questions? So any other questions from the panel? Dave, go ahead.
Hi, Dave Wittenberg from Mathematica, and my question is actually for you, Danielle. You had you're excited about this, I can see. So let me start with an opening. I really like the chart that you had at the end showing what happens to disability status by age. Things like learning disabilities actually decline with age, whereas cognitive disabilities increase. And my question to you is, has the Census Bureau thought about any of the measurement issues associated with this in terms of childhood versus adult disability? And so my specific question is, when you're a child and you have a learning disorder, that disorder doesn't go away when you're age 24, 25, but we often don't measure it. And your chart was actually one of the first that I've seen that kind of shows this measurement issue really clearly, in my opinion. So I was wondering if the Census Bureau has thought along those lines, or alternatively, if I'm just misinterpreting your chart.
We're getting some feedback somewhere, but okay, go ahead.
So, for me, when I look at that chart, what I see is learning disabilities that tend to be diagnosed more in children. And as the culture has changed, diagnosis has become more prominent in the media over the last 10 years. And so I don't know if what you're seeing is an increase in disability in the younger ages or an increase in the diagnoses of the younger ages. You see that a lot with like the lower incomes too. If you don't have money to pay for a doctor to diagnose you, then you don't have a diagnosis. So I think that is probably playing into parts of that. And then as kind of the culture continues to shift and more awareness becomes, I think you'll see an increase in reportings in adults. But as things stand right now, people who are in their 30s or 40s or 50s just probably never got a diagnosis and have just kind of dealt with it. And to the extent that that feeds into how people self-report, I think that affects what you get to say by age.
Sure. Yeah, for sure. Yeah, a follow-up on that question, Danielle, just so that you can publicly speak more. So in terms of who's not captured by the questions, it's really nice to see that the answer to who answers this question is going to change with regard to that age of that person. So that's a really salient result, that dementia might be picked up as you're going on, depending on, across the age spectrum. Did you find anything like related to, I know SIP doesn't have obesity, but a lot of the conditions, I looked at the wave 4 and wave 6, 2008, and I remember seeing people who were not responding were kind of like obesity-related conditions, heart disease, various conditions where maybe the ACS questions needed a stamina-type prompt, or Did you find anything that would suggest ways to change the 6-question sequence?
Short answer is no.
You wouldn't add a work limitation question? Come on.
It's, so, you asked, is there a way to change them?
Or add to them.
So the 6th set is, the ACS is hard to get changes through.
Yeah.
Starting around 2014, 2015, we ended up with a congressional inquiry. We had to provide legislative justification for every question that was on that survey. And to the extent that we want to look at new things, we have to provide federal justification to get a question added, to keep a question. Our branch has been looking into ways or different things to add, but kind of negotiating that because Congress has to give us approval on the ACS. It's more rigid than, say, the SIP, which allows us more freedom because the Bureau kind of does that on our own. So that's kind of that push and pull. The ACS has a big population, it has a congressional mandate, but it also has more rules.
Yeah, for sure. And that's one big difference between the ACS question set that's used in lots of surveys and the Washington group is that the response option, as Julie said, is a scale in the Washington group where the ACS is pinned on serious, serious difficulty. And that's because of a need for yes-no responses and the number of inches that you have in the ACS. Danielle mentioned something that's worth noting is that these statistics are always under threat, right? There was a privacy concern. So an ACS person, enumerator, was shot in Texas, right? And so there's concern about the questions, about asking personal questions. And the self-care disability question was really one that was really the focus of some concern. So.
It's
So
funny
it's always
because
helpful.
the disability questions are actually less invasive than income. People are more willing to answer the
Sure.
disability questions than they are to tell the government how much they make.
Sure. Or their plumbing. Various things.
Internal plumbing and toilets are very important for very
Yeah, I know.
specific locations.
Okay, so are there any other questions from the audience? Thanks.
Hello, this is Mark Myers again. I was thinking about what Jennifer had said about the NDDD, and the people that have DD have been identified as being deaf, and people that are DDD are developmental. So looking at the environment of the home, work, or school, and then looking at communication, let's say caption, it's very common. So looking at merging those environments for DD and DDD people, thinking about deaf people with disabilities, and placing them into a living situation like a group home or into a hearing environment where they're DD, it's actually a very common thing. There's cost involved, there's policies, there's program planning, and so on. There's so much that's integrated within that whole process. So deaf people or DD people tend to be isolated in their home environments and when they're placed with other people in hearing people in DD environments. So how do the staff communicate with them? Are they signing? Are they gesturing? So they're feeling like they're kind of being pushed and left into a corner. So their health is declining much faster. The advocacy for deaf and DD people put into regular or a standard group home versus people that are put in with staff that are skilled to communicate and work with those people to help maintain their, standard of living. So looking into all that over the whole country or other countries, would be the recommendation. My experience in New York, in Albany, New York specifically, they had established a group home for deaf and DD people, and they had them separate from the hearing DD people. So for daytime, they would go and they would do their regular activities, they would work, they would do things, they would interact with everybody. And then they would have the comfort knowing that they can go back home and integrate with people that are on their same level and experiencing the same needs and accommodations that they need. So that's something you guys might want to consider for yourselves.
Thank you for pointing that out. It's interesting to know more about that, and I'd be interested in talking with you more about what you are observing and learning and hearing and understanding in terms of what's going on in states. So thank you.
Yeah, just to follow up on that, there are a number of data collection efforts funded by AIDD, and you mentioned the indicators, the core indicators states. Some of those materials are out on the table out front, and several of the projects from the national projects of super duper importance are all putting materials out there. We thought about creating a panel, but it was just too late to do that. But in any event, those materials are out there for people, and for people on the internet, give us a shout and we'll send along information. Any questions? Any other questions? Oh boy, 1, 2, 3, 4 questions. Holy smoke.
Julie, this is a question for you. So that sponsorship thing is very interesting.
The price keeps going up.
I was going to ask what, there's all sorts of questions there. What the price is, who could sponsor, how is it only open to other federal agencies, is it open to anybody? Is there some criteria for how you're choosing? I mean, what can you tell us about this?
It is not only open to federal entities, and we have had examples of sponsored content that came from elsewhere, even from within our own organization, like CDC. Generally, there's an application process, and typically those questions also need to be tested in our design lab. So we wouldn't put a question onto the survey that hadn't gone through some kind of review, and how much cognitive testing is necessary depends on the type of questions. If you're adding, a number of long established questions that are fairly common, maybe less cognitive testing is necessary, although I might add that most of our long-standing indicators have never been cognitively tested, and that, all the recent content has had to go through rounds and rounds of it. The price, it's about $150,000 a question. It depends, questions can be, unfolding scheme questions, it really depends on how much administration time that question takes. But this would be a very positively engaged experience. We are not looking to, really just kind of minimize that lower half of that survey time. We're very much interested in looking to partner. It is where some of our most interesting content has come from, some of these supplements that have been sponsored content.
Next question.
Hi, Amy Lulinski from the Coleman Institute for Cognitive Disabilities, and I have 2 comments. One is to the person in the back corner, and I'm sorry, I don't know who it was, but first brought up the need for IDD-specific data. I am so excited we're having this conversation. I wanted to comment, the person had said that it's so important to make sure that we are capturing those folks who are outside of the formal DD service system. Was that you? And I wholeheartedly agree. We know that over 3/4 of people with IDD live in their family homes and are not receiving any formalized support. So I did want to mention that the ARC of the U.S. teamed up with the University of Minnesota and did a survey called Family and Individual Needs for Disability Supports, or Services rather, or the FINDS survey. And they were specifically, and I was involved in that, self-disclosure, and they were specifically looking to get data for those folks who are not in the formal service system. The results are forthcoming, but I do know that recruitment was still difficult. I mean, it was very difficult even to get folks from, from diverse populations. So that was my first comment. The second comment was just to Andrew, thank you for mentioning the super duper important projects. That's the projects of national significance. There are 3 data projects that are longitudinal in nature. Andrew was kind enough to offer us some space to display some things. There are 3 projects there. One is focused on employment and IDD. One is focused on where people with IDD live. And the third, in the project I'm involved in, focuses on public expenditures for supports and services for people with IDD over the past almost 4 decades. So that's out there. So thank you.
Hi, I'm Robin Schaffert, and I grabbed the mic. And I just wanted to ask Jennifer a question about the focus on data collection for people with IDD, which is whether you are focusing on, and if not, suggest that you do, on the people who have dual diagnoses of significant mental illness and intellectual and developmental disabilities. You know, estimates are that that's at least 1/3 of the population of people with IDD, and I think we have a dearth of information about those people. What we do know is that accessing services, accessing education, building full and independent lives in the community has a second layer of complexity to it, and I think doing more work on that's just really critically important.
So I'm shaking my head, yes. And I agree. I think that is really a critical area of need. I obviously spoke broadly about the data needs related to the IDD population, but you're right. I mean, when it comes to individuals with intellectual or developmental disabilities who also have mental health conditions, that's one of the most challenging populations to serve and retain in the community. And so if we had better information about that and better ways to identify that population, we could serve them better in the community.
Yeah, there are program statistics for that population through the Center for START Services at the University of New Hampshire, who is in a number of states, and they're collecting longitudinal data on individuals, but that's administrative data. Population-based data of people who are not being served by these programs, which there's a substantial number of individuals. That's where the population-based statistics come from, and the need for them. Because it'd be nice to know who's not being served. So, with that, I'm going to wrap it up with a plug. So, okay, just.
So I have 2 questions from online. The first one is, we use the RSA data sets frequently to examine employment for people with autism and IDD. We are concerned about the removal of wage data from future data sets. Is anyone working on addressing this? To clarify, this question is specific to the RSA 911 annual data on closed VR cases.
Good question. Is there anybody from RSA? Wittenberg, do you know? Removal of wage data? Yeah, there are the new requirements coming in. I think there are people I know some people who are engaged in that process of revising the files. But we can raise that issue for sure. It is problematic, but there are also privacy concerns that are very difficult to work with. And either you don't get the data or you get the data scrubbed from certain personal identifiers.
Okay, there's one more question. Within all the data sources discussed, what is the best way to access and find data on rare disorders within the population of disabilities? For example, where can one find basic demographics on persons who have a rare disorder with components of IDD?
Yeah, so short answer is there are no such sources. Probably the best source for, say, IDD-specific conditions nationally is our program data. So program data from the Social Security Administration. You used to be able to get online through Maximus zip code level information about people with IDD who receive Social Security benefits. I don't think that's online anymore, but that's really where strong use of administrative data could be improved. But again, population-based sampling, going out and doing a sample that gets at rare incidence, low incidence conditions is really, really difficult. Even with the ACS, you can start mincing things very closely and run out a sample really quickly and really have certain samples that are so small you wonder if they're picking up the population. So that's my best answer. Any other questions from online? Good, no? Okay. So we have lunch here for the people online. We'll gladly send you some leftovers if you send us an email. But thank you, everybody. This has been a great panel. Thank you.
Thank you.
Woo, 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 for the government folks. All right, thank you very much. Everybody will break for lunch, and then we'll be back at 1 o'clock, I believe.